The reason why identifying large vessel occlusions is so important is because we know that thrombectomy, we can do it up to 24 hours, whereas in TPA is only good for 4.5 hours. Now that might change with new studies, but the fact of the matter is you're increasing the time window and the people that you can help by screening, especially using VAN, because it's the most sensitive tool out there. Using some sort of screening tool up front has been shown to help with getting the patients to the right place at the right time, but also helps within the hospital to get patients to the endovascular suite or the proper treatment much faster. There's a slide here which looks at the number needed to treat, and we're really comparing going to the cath lab for a heart attack, right, versus endovascular suite for thrombectomy. And as you can see here, you're basically the number needed to treat is 4 times smaller. So you can see going to the cath lab for a heart attack, you need to treat 17 people to make a difference in one person's outcome. Whereas for endovascular stroke, it's anywhere from 3 to 7. And so with an average of 4. So you're talking about something that's 4 times more effective than going to the cath lab. I'm not saying you shouldn't go to the cath lab. Of course you should, because a 6%, 10% difference is good, but a 25, 30, 40% difference is even better, especially if it's functional outcome. And you can see that massive benefit actually extends up to 6 to 24 hours. So this is a slide depicting that if the reason why we're trying to identify these early and why I think it's important to do it, not just in the field and for triage and bypass, but I think it's important for every person in a primary stroke center to know what VAN is and what cortical symptoms are. Because here we did this UP study in Phoenix, which showed that out of people with NIHO scale of 6, which is what the guidelines say should be screened for LVO, only 40% actually got a CTA and 0% had an LVO screen or some sort of screening done. And out of those 40%, so that means we missed 60% of patients that should have gotten a CTA. CTA was read in 1 hour and only 8%, and transfer out in less than 2 hours was only 15%. That means 85% of transfers from primary stroke centers took greater than 2 hours. And so it's very important to be able to identify these patients, again, because you're doubling the people that are functional. So how I'd like you to think about this is basically there needs to be a paradigm shift, okay? And the paradigm shift, just like you think of MI, myocardial infarction and heart attack, there's 2. ST elevation MI, non-ST elevation MI. ST elevation MI, cath lab right away, boom, 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 go open it up. You should think of stroke as the same exact way, which is what? Which is LVO, large vessel occlusion versus non-large vessel occlusion. Non-large vessel occlusion, TPA, or if they're outside of the time window, medical management aspirin. LVO's positive. TPA if they're within the time window. If they're not, going to the neuroendovascular lab. And that's basically what you should think is now it's time. We know that this is one of the most powerful treatments out there. So all of us need to change our paradigm shift. Primary stroke centers, comprehensive stroke centers, EMS, ED physicians, everybody needs to be ingrained into your mind even more powerfully than ST elevation MI, non-ST elevation MI. So here is what we did by using VAN up front or any screening tool and doing CT, CTA up front, calling the transfer center or the endovascular team. We actually decreased our door to endovascular time by 50%. Instead of doing CT, go back, give TPA, go back for CTA, then call the endovascular team. What we do is we do everything up front. So it's called parallel process. Boom, boom, boom. Everything at once. All decisions, 2 seconds. VAN positive, call CT, CTA, call the endovascular team. Boom, done. You've already saved like an hour at least. And that's basically our experience. And that has actually been reproduced not just by us, but by other centers as well in Florida and in other parts of the valley in Phoenix and in Texas as well. So multiple areas that have done this have shown this. This came out, our sister hospital did the same thing in the West Valley of Phoenix. I'm over in the East Valley, and they had the same exact results. They actually decreased their door to TPA time from 56 minutes to 35 minutes, and their door in to door out from 110 to 91, and it's actually down to closer to 80 or 70 minutes now, which is very powerful. So this is why screening is so important. Here's another one, the one I mentioned out of Florida. Again, they decreased by doing CT, CTA, and VIN positive patients, they decreased their door into endovascular time from 116 minutes to 56 minutes. That's an hour difference. And so it's very powerful using it. They did that in Connecticut as well, and they actually showed that they decreased unnecessary transfers by screening and with VAN and getting CT, CTA to see who needs to get endovascular treatment. So that's section one. And section one is like, I want you to know that you're making a massive difference, because that's the key. You're doubling the people that are functional. That means that they can go back to work, right? I've already proven that. Now I've also showed you multiple examples: West Valley in Phoenix, East Valley, Florida, Texas. If you do the screening up front, do CT, CTA, activate everything, you actually decrease times by an hour, which can be 10 to 30% difference in outcome as well.